Hi, my name is Matt, and I'm a second-year med student, and this is part 2 of my autonomic nervous system talk. And we're going to be doing the sympathetic drugs in this section. And we're going to start off with on page 232 of the 2013 first aid, which just covers those toxins that inhibit the autonomic nerves, because I forgot to put that in the first video. And so just a quick run through looking at that. On the cholinergic side, it's pretty straightforward. The Vesamicol there, vesicle, it's going to be inhibiting sort of the uptake into the vesicle of the acetyl-CoA, and then hemicolinium halts the choline uptake. Also, you want to think like a hemidesmosome kind of thing. It's like on the border there, and it's blocking entry of the choline. And then botulinum, hopefully you've picked up the Clostridium botulinum has the flaccid paralysis, and so this is how you get flaccid paralysis. Is the toxin is you think that that's at the bottom, it's at the end of the axon there, but it's gonna it's gonna prevent the fusion of the vesicle with the plasma membrane, so it can't actually release the vesicle, and I think it does this by inhibiting SNARE. I want to follow up on that. I'm pretty sure it does. And then, so that's pretty easy. So vesicle, Vesamicol, hemicolinium, halts choline, and botulinum is at the bottom and is the last step that's going to block the membrane fusion. And then the noradrenergics, metyrosine, it's going to block the cholinergic synthesis pathway, where tyrosine goes to DOPA. And so that should be pretty straightforward. Reserpine. So reserpine, I think recycling reserpine, or even like a serpent, like you get like the snake poison, supposed to drain the wound. So the reserpine, recycling. What are we recycling? So this is again the loading into the vesicle of dopamine. And then you got your cocaine, your amphetamines, and your TCAs, and all that blocks reuptake. And TCA, tries. I think it's like tries to be cocaine or amphetamine, TCA. So that's, remember, like it goes with those guys. And then amphetamine amps up the release of the vesicles. And then you've got these weird sounding ones of guanethidine and beryllium, and there's a couple ways to think about this. You could think of guanethidine as like guarding the vesicle. It doesn't let it out of the membrane. You could think of that beryllium as being the like equivalent to the botulinum toxin for the parasympathetic pathway. Or you could, I put them together, that GB is called the goodbye blockers, as in like the last step would be the vesicles fusing with the plasma membrane, and that would be saying goodbye. And those two block that step, the goodbye blockers. So anyway, that's those. I just want to mention them before moving on. So now we're going to do the sympathetic chart there. You probably see it behind me on page 235. So I'm just going to give you kind of a way of walking through. I'm a big believer that the pharmacological drugs tell you what they do in their name, and you've seen that, I'm sure, in a lot of modules by now, but I mean, they really do, and if you just look at them the right way, you can see what they're trying to tell you. So let's start with epinephrine. Actually, hold on, let's start with this. They put dopamine on here. There's only one, the dopamine receptor, there's only one that's going to have activity on dopamine receptor, and guess what? It's the dopamine. So let's just put that in now and then never talk about it again. So that marker's not working. That's embarrassing. All right. There we go. Dopamine. Put a little low there, a little L for low. That's going to be important later when we talk about actual clinical applications of these drugs. But so there we go. Got dopamine out of the way. Now let's actually talk about everything else. So epinephrine, epidemics, affects everyone. So it's going to boost everything, right? Everybody's getting a boost. Okay. All right, great. All right, and then and then norepinephrine. It's not quite an epidemic, and it's going to affect all the alphas and then beta 1. So it's leaving out beta 2, which is going to be important later when we talk about glaucoma. But the other thing that's important to note about norepinephrine is that it has greater alpha activity than beta 1 activity, and we'll talk about that more later. But I should probably just mention now that if you see a drug, it's just like a general rule, it's not going to work, and the exceptions are right there behind me, but if it ends in INE, I tend to think that it has something to do with alphas. Doesn't necessarily mean it's going to stimulate the alphas the most, but it should have something to. Well, let's move on. So isoproterenol. Iso, it's isolating something. Promoting. It's only promoting the alls. And when you see all, you should think beta. All is beta. So, wouldn't you know, it stimulates beta 1 and beta 2 and no alpha activity. So, and it treats them equally. So that's great. And then dopamine. Let's just fill this one in. It's got a neat clinical situation where you want to keep it in mind, but it's got a kind of a weird pattern. So the way I think about it is like if someone's doped up, that's not good. So the lower you go, the better it is, because remember dopamine 1 protected our kidneys, and we'll get into the clinical situation in one of these lectures, but the idea that, you know, if you had too much dopamine, then you would, when you see it in the chart, it's high. Too much dopamine would trigger the alphas, and that would cause vasoconstriction and might hurt the kidney. So lower dopamine is good, and it's good for the kidney. So you want to put that it does affect it does affect everybody, but the important thing is just to know at what kind of doses are you working with. And it's really nice that the betas are kind of in this middle dose, and then the dopamine is in the lower dose. Then we got dobutamine, and like my rule, right, INE, it's going to have some alpha activity, so it does. It's very little, but you just know to expect it. And the reason you shouldn't be focusing on something else is that dobutamine, you could think of it as debetamine, as in like you should be stimulating beta, or I think of it as the lubdubamine, because you use this to stimulate beta 1 in heart failure patients. Also, in cardiac stress testing, because you want to just stimulate the heart and not how it would normally perform, and not vasoconstriction if you gave like epinephrine or norepinephrine, because then you would just increase afterload and that would put extra undue stress on the heart. Right? It doesn't make sense. You want to just stimulate the heart, so you can give dobutamine, the lubdub, to stimulate beta 1 more so than alpha. So we're just going to put that there, and then let's see, phenylephrine. So this is another kind of general rule I'm going to include. Phen is a friend to alphas. Phen is a friend to alphas. A lot of these drugs we'll be talking about in this autonomic series is they'll have phen in the name, and it's going to have something to do with just alphas. So if you see phen, it's just alpha. And phenylephrine is a alpha stimulator, and I think it's both of them equally. So great. Now albuterol. So albuterol is it's got an all in it, so I should be thinking beta. And hopefully you talked about this enough in pulmonary modules, but the idea that we want to protect our beta 2s because those are involved in vasodilation, and that helps in with people with asthma. When you want to give like beta blockers for hypertension and stuff, we want to pick a beta 1 selective blocker. We'll get to that later. But albuterol and salmeterol and terbutaline, they're all beta agonists. And so the important thing there is just to note that it is an agonist to both, but it primarily will pick beta 2. So It's got some activity, but it's a big beta 2 person. So let's just think about that real quick. Isoproterenol, I want to treat my betas equally. Debutamine, I want to stimulate just beta 1, and then albuterol and salbuterol and terbutaline, I want to favor my beta 2s more so than my beta 1. And then Rotodrin is just a beta 2. So that's great. And then I threw clonidine out here, which is on the next page in first aid, and hopefully you just remember that clonidine and alpha-methyl-dopa are alpha 2 stimulants. Now you might say, well, Matt, that rule you told me about the enes doesn't really work with Rotodrin and terbutaline, and you'd be right. So, but ironically, those two you can actually kind of lump together as exceptions because they're used for very unique situations, which is that Rotodrin is used to prevent sort of a premature birth and prevent uterine contractions. And so the mnemonic I use for that is uterodrin. Uterodrin. And for terbutaline, it's got that TER in there, that ter, and I think about teratogens, teratogens and those, how those affect, pregnancy. So like this idea that like a terbutaline, it will somehow dissuade the pregnancy, stop the pregnancy, and so terbutaline is a beta 2 agonist, and is used to stop premature pregnancy, and just like uterodrin. So those are my two INEs that end in INEs, but they don't have any alpha activity. But they go together as exceptions in that they prevent premature uterine contractions. Uterodrin and terbutaline, and then also another distinction you got to make here is with the albuterol and salmeterol, and that is, so if you have an albuterol, right, salmeterol is a sustained albuterol, if it's a longer acting, or you could look at meter and think it's running the meter, so it's longer acting. Running the meter, sustained albuterol, salmeterol, versus albuterol, and I think that's that. So now we're going to go into, before discussing the functions of each of these, we're going to go into the charts on the next page, where it compares. It's trying to make some important things between alpha and beta stimulation and how that affects, and we'll discuss that, and then we'll just run down the list of how all of these are used kind of clinically. So I'm going to erase this, so hopefully you're looking at it right now in your first aid, and that's done. So I'm just going to erase what I need to show you guys. So, all right. So the first point they try and make is that what benefit do I get of picking a alpha and beta agonist versus just a beta agonist, and what kind of physiological effects are different between them. So first it compares norepinephrine with isoproterenol, and it's looking at the blood pressure, right? And then it's looking at the heart rate, right? So, oh gosh, hope that's coming through. Sorry. So, the norepinephrine, right, has alpha greater than beta. And why is that important? So, if we think about where those receptors were, right, we said alpha is our peripheral vasoconstrictor, and if you think versus beta, which is beta 1, which is dealing with the heart. So if we think about when pit against each other, who has a greater effect? So you've got the vasculature, which if you add it all up is however many miles and miles of vessel you have in your body, right? Versus the heart, which is like the size of your fist. So who wins out when you're dealing with regulatory mechanisms of blood pressure? So it should be the thing that controls the miles and miles of vessels, and it is. So when alpha is stimulated, as it is in norepinephrine, which remember is 1, 2 of alpha and just beta 1 a little bit, you get an increase in the diastolic you get an increase in the systolic, and so overall you get an increase in the medium. And it's hard to represent just freehand, but it's trying to. There's a concept that well, we'll get to it later. It's better represented in the next example. Sorry, just hold on. So increase in diastolic, increase in systolic makes sense. I'm vasoconstricted, so my base diastolic pressure goes up. I'm also adding on to that some beta 1, so my heart's pumping more. So I get an increase in systolic, and mean pressure goes up. And then it describes the heart rate being that if your mean arterial blood pressure goes up, then you should get a reflex bradycardia on the rhythm, right? Because your body's trying to get back to equilibrium, and you just forced it into a high blood pressure state, so it's going to do a reflex bradycardia and get you down. Now, with isoproterenol, it's just beta. So you say, okay, well, I got beta 1 and beta 2. Now, who wins out? Again, miles and miles of vessel or just a heart. Guess what? The miles of vessel win, and when we have beta 2, remember where it really stands out is that it's vasodilatory, dilates vessels. So when you stimulate it, the diastolic pressure, which is going to be based off of sort of the overall tonic contraction of the vessels, it's going to drop because they're going to dilate with the extra beta 2 stimulation. So diastolic comes down, and then you're stimulating beta 1, so that kind of tries to hold its own a bit. So the systolic doesn't really drop because the heart's going to be able to pump more with the beta 1. So they kind of show it like plateauing, but not really coming down all the way, right? It plateaus, but you still have a mean drop in blood pressure, so there's a reflex tachycardia, right? Because you drop the blood pressure, and now your body's trying to put out more blood so that it can maintain pressure putting out blood at a faster rate to maintain pressure. So that's those two concepts. So just appreciating that when you provide an alpha agonist alongside a beta, the alpha wins out, and that when you just give a beta, now the beta 2, that vasodilatory effect, can outweigh the alpha and drop your blood pressure. So now the next concept they want to show with these drugs is the stimulating alpha and beta, or just stimulating alpha in the presence or in the absence of an alpha-only blocker. So what they show here is epi with no blocker plus no blocker, and then they have epi with a blocker. No, okay, plus a blocker. It's running out on me. And then we have alpha only. So who was our alpha only? Alpha only phenylephrine. So phenylephrine versus with no blocker, right? No blocker, and then phenylephrine plus blocker, right? So, and the blocker, spoiler alert, the blocker is phenytolamine. So you probably could have guessed that was an alpha-only blocker because it's got phen in it. So phenytolamine, it's only an alpha blocker. And again, preview, phenytolamine, if phen was a friend, well, at one point, it took a toll on the friendship. Phenytolamine took a toll on the friendship, so it's actually a alpha blocker. And it's no longer the phenyl friend of alpha, it's the phenyl blocker, and phenytolamine, toll in a relationship. So that's what they're using to just block alpha. So anyway, back to this, epinephrine plus no blocker. So we know it stimulates everything. At the end of the day, this also demonstrates the concept that if you're stimulating alpha and beta at the same time, alpha is a stronger guy. So even though, yes, you're stimulating, you might say, oh, shouldn't you vasodilate and whatnot? No, alpha, when you're pitting alpha and beta against each other with the same sensitivity, alpha wins out, and you still get an increase. So it looks just like the norepinephrine curve from the other thing. And then when you give an alpha epinephrine plus the alpha blocker, that's just basically saying there's no alpha stimulation. So we're just stimulating then really the beta, and it looks just like the curve for isoproterenol, right? And then when you give phenylephrine against phenytolamine, phenylephrine without phenytolamine, you get an increase in diastolic and an increase in systolic, and there's still a mean increase. And I got to kind of stop right here to talk about this principle I mentioned I would talk about earlier, and that is that whether or not you get an increase in pulse pressure. So pulse pressure is the difference between systolic and diastolic pressures, right? So if we think about norepinephrine had an alpha and beta 1 activity, alpha 1 and 2, beta 1. And so the alpha activity is going to constrict the vessels, right? So that's just going to set a new base pressure for everything. So diastolic goes up and systolic goes up. And then when you add on a beta agonist, now you've got extra contractility and chronicity in the heart, so you get a further increase in the systolic pressure. So there's an increase in pulse pressure. And I couldn't really draw it that well, but they kind of show it in that drawing in first aid. And then the idea that in phenylephrine, you're just giving alpha. So there's no increase in how the heart's going to behave for these purposes. So the delta pressure, the pulse pressure, the delta between systolic and diastolic, that is going to stay fixed, because you're just increasing the baseline, and there's no extra little pulse on top from the heart, because alpha 1 is not going to affect the heart. So that's a really simple way of looking at that. And then finally, phenylephrine against a phenyltolamine. They're both alpha 1,2 agonists and blockers respectively. So it's just a flat line, because they're just canceling each other out. And that's what they're trying to show you there. So now hopefully you can refer back to your graph there to kind of walk you through, well, what scenarios would we be using these drugs for the agonists. So an epinephrine you could just give for someone who's like low blood pressure, right, hypotensive, and that'll just raise your beta 1, it'll vasoconstrict and bring that all up. But if you do that, you got to be aware that there could be injury to the kidney. And this is the same thing with the norepinephrine, really. It's this idea that if you're just constricting the periphery, you really need to be aware of how well your kidney's doing. Because if we just quickly think about the kidney, what it can do, right? So when you want to raise pressure, if you raise everything together with a peripheral vasoconstrictor, that's going to close off that afferent arteriole, and it's not going to be able to dilate it that well, so you could reduce perfusion to the kidney. So that's just something you got to be aware of. And then it talks about uses like glaucoma. So if we think back to the eye example, right? We're going to talk about other uses for it, but you could imagine open angle, and really when epinephrine, you should only think open angle glaucoma, how that could dilate the eye, and that would dilate the eye and allow for more fluid to come through in the glaucoma, and so that's we'll get to that later. It talks about asthma. Obviously, you want to stimulate like the beta 2 in the lung. Beta 2 in the lung, kind of an exception. It's beta 2 in the lung, really strong, so that will open up that. And alpha 1s will constrict blood flow to the glands. And again, that's a glaucoma example, where if you vasoconstrict to a gland, the gland doesn't make anything, kind of thing. So if you vasoconstrict to the ciliary body, it can't make aqueous humor, so you got dilation of the pupil and decrease in production of humor, and that's the open angle one. But again, we'll get to that later. So anyway, that's that one. Norepinephrine is kind of the same thing, and again, they mention the renal perfusion. The isoproterenol, this is kind of, it's more of a cardio thing, but it's used for torsades and also for bradyarrhythmia, but also noting the risk of renal injury. So, well, not renal, it says can worsen ischemia, which, I mean, the kidney would be one of the things I'm concerned about. So, how does that play out? Just quickly, torsadipine, if you think there's like that delayed repolarization of the heart, and you know, if you just think about sort of that thing, it shoots up, then it comes down, it's supposed to do this and come down, right? So if there's a delayed repolarization, another action potential comes through, and this thing gets contracting really quickly and whatnot. And but it's not coordinated very well now, because everyone's working at different times, kind of thing, in the ventricle, and it's not quite VFib. It can shift to VFib, which would kill you, but it's not good. So what you do is, I think, you give this isoproterenol, which will stimulate beta 1, and actually that you're like, well, beta 1, won't that increase the contraction time? Yes, it would. But it doesn't even, it sets everything a little bit quicker, so like everyone kind of, I think, how I think that it lines up together. So now, yes, it's beating faster, but it's beating faster in synchrony, so you've like cut short all of these like early after depolarization things, and you've brought it all in alignment, so now it's actually able to constrict appropriately to pump out blood. Whereas one of the things in torsades is syncope, because just like any time the heart's beating too fast or fibrillating, the idea that you're not actually getting a good ejection fraction. So this is like, yes, it's beating really quickly, but now it's beating appropriately. And then the bradycardia, bradyarrhythmia, right, that makes sense, it beefs it up, but just like we talked about isoproterenol, right, you get a drop because the vasculature outweighs the heart, so that hypotension, you'll still drop the blood pressure, and that will could risk damaging an ischemic area. So you got to be careful with that. Dopamine. This is a good example of when you really want to treat the kidney. So dopamine, we know it can, at low levels, help out the kidney. Remember, it dilates the smooth muscle vasculature. We know that at medium levels, it can stimulate the heart, and then basically at the high levels, it's going to trigger a vasoconstriction of alpha, right? So what you can do is, if a patient comes in who's hypotensive and has renal failure or renal disease and whatnot, and you're going to try and boost their pressure without hurting the kidney, you could use the dopamine, because you can get a low enough dose where you're going to trigger some beta 1, get that heart pumping a bit more, but also dilate the vessels of the heart so that they don't have a peripheral vasoconstriction such that the kidney is becoming more ischemic. So that would be a good way of, because otherwise, if someone's just hypotensive and you're not worried about the kidney, you can give them epinephrine, norepinephrine, whatever, you know, or pressors and all that jazz. So that's that, and then dobutamine, the heart one we talked about already. Signaling out beta 1 can be used in heart failure. This is where you're going to want to. This is not in congestive heart failure, because we don't want the heart to try and work harder when it's trying to tell you it can't, because it's congested. But once you've like put them on those diuretics and stuff and got their volume down, and you want it to pump more, you can put them on the dobutamine to get it going. And then let's see, what else? Phenylephrine, so an alpha agonist. When would I want to use that? Like we said, it talks about, well, rhinitis. Why? Because if you vasoconstrict the glands, then it will stop mucus, stop secretion. So, you know, vasoconstricting the mucus glands in your nose will stop running. We know that the alpha activity for the eye is going to help dilate, so it talks about eye procedures. You want to dilate the pupil so you can get in there. That makes sense. And then again, it talks about hypotension and wanting to constrict that. The albuterol, you know, that the classic asthmatic patient, the short-acting beta agonist, right? So you do that. Salmeterol for long-term, sustained albuterol. And then talks about the terbutaline, which was the premature uterine contraction. So that's all there, and that's great. And then and I think that's it for the agonists and stuff. There's some stuff there about the cocaine, but you could predict how that and the amphetamine. Nothing in there is really surprising based on where we talked to how it acts. I don't think. And anyway, so you can look at that. So that's the agonists. Now we're just going to talk about the antagonists. And unfortunately, it's a lot shorter list. And based on the principles we already talked about, it's going to be really easy to remember. So Phenoxy, this is on page 237. Phenoxybenzamine. Okay, phen, I know it only works on alpha. And phenoxybenzamine. So I think of this like it means business. And why does it mean business? Because it's an irreversible blocker. So it means business, and you use it for pheos to drop the pressure before messing around with that thing, because you start cutting it out and it starts releasing, all these catecholamines. It could cause a surge in blood pressure. So you give this, it's really strong, and it's good, and then all those catecholamines floating around won't be able to enact their effect. And then phenytolamine, taking a toll in the friendship we talked about earlier. It's alpha-1,2 blocking, and this is used for overdose of catecholamines because someone on an MAO inhibitor, monoamine oxidase inhibitor, which is the enzyme that breaks down the sympathetic neurotransmitters there, that is going to, they get a buildup when they eat the wrong diet, the tyramine-rich diet, the cheeses and wines thing. So if they got too much, again, just like how in the pheo, you've got too much catecholamines and you want to just stop that dead in its tracks, you use phenoxybenzamine. Phenytolamine is a reversible one because friendships can always be repaired. So, and yes, it's reversing and it's blocking it. So, but you would use it in that. And then the alpha-1 selective blockers are end in osin. Osin, the way I kind of remember that is like if alpha-1, it's like alpha, it's the alpha, it's 1, it's the best, right? And you're blocking it, isn't that a sin? It's like a sin against the alpha-1. It's like that was the best one, it's alpha-1, and you're blocking it, it's such a sin against it. So osin, anything that ends in osin is an alpha-1 blocker. And again, you could see where you would use that in hypertension to vasodilate by letting the beta-2 run wild. Or you can use it in BPH because in that one, if you remember, we talked about alpha-1 can't see P climate tree thing. That sphincter in BPH is the sphincter in BPH. It's in the bladder can be constricted, and so if you add an alpha-1 blocker, that kind of relaxes it a bit, and they can pee more because there can be like a tonic contraction there that impedes flow of the urine. So in BPH, you can relax that with an alpha-1 selective blocker, the tosin. It's a sin against the alpha-1s. And then the alpha-2 blocker is Mirtazapine, the Mirtazapine, right? So this thing I think of, okay, so Mirtazapine, it's not a clever name, it's really hard, it could be hard to remember. So you're going to have to practice with it, but to help remember the side effects of it, if you can think of it that way, Mirtazapine has an increase in appetite, and it's also used as an antidepressant. So, and it's in the psych section, so you will see it again. And so here's how I kind of put it all together. So alpha-2, we talked about earlier, anytime it's alpha-2, things are down, right? So alpha-2 stimulation drops blood pressure, clonidine, and then essentially you can think about it, it's a downer. Like it's been shown to be linked to depression, right? This alpha-2 receptor. So when you target it, you can actually treat depression with an alpha-2 blocker. So there's that effect. But what's odd about it is that even blocking it can lead to sedation. So kind of a different kind of downer, right? But I told you in the first lecture, anytime you see alpha-2, whether stimulating or blocking, just think sedation. It's always bringing stuff down. So it's always bringing stuff down. So even when you block it, you can lead to sedation. So sedation there. And then to remember the appetite, increased appetite, Mirtazapine, to me that sounds like marzipan. like that cake dessert. I've never tried it, but I remember hearing it somewhere, marzipan. So marzipan. So if you can think marzipan, mirtazapine, to me, I'm gonna have to try and force them together. That they sounded like mirtazapine, marzipan, mirtazapine. They're becoming one word now. I'd see it, and that's the increased appetite because it's a cake. It's delicious. You want to eat it. So there's that, and then. If you think it says it increases cholesterol levels, if we said that increased alpha 2, if alpha 2 decreased lipolysis, right, then to block it would increase lipolysis, and so you'd have all these extra triglycerides, cholesterol running around, so serum cholesterol would go up. So that's that, and then the beta blockers are on the next page, 238, and so all the ones ending in just OL for a general rule, all the ones just ending in OL, right? Isoproterenol, albuterol, salmeterol, they all were agonists, right? So anything in OLOL is going to be a beta blocker. But the question the thing you have to be able to differentiate is, well, is it a non-selective beta blocker? It blocks them equally. Is it a selective beta blocker? In which case it does technically block both, which is important when we get to the glaucoma thing, but for right now that it partially inhibits one more so there's ones that just inhibit beta 1 more so than beta 2. And then there's a couple on here that are really atypical in the idea that they are alls, and they kind of sound like all alls, but they're not quite. So there's like illol and allol, and they're carvedilol and labetalol, and they're not exactly spelled like OLOL, but they're ILOL and ALOL, and those ones are non-selective beta blockers plus alphas. So how do we bring this all together? So if the general rule was OL is beta agonist and OLOL was a beta blocker, we'll start with that premise. So first off, and here's how I organize it in my head, and you could do it differently, but I start with the premise that yes, OLOL should be beta blocking, but I start with the premise that they should be beta 1 favoring blocking, okay? So that's how I start. I say, no, yes, they're beta blocking, but they should start beta 1 blocking, okay? So how does that work? So there's the mnemonic in first aid, which I guess is okay. It's a beam, and there's betaxolol, atenolol, esmolol, metoprolol, and you probably heard metoprolol a lot. That's like the classic beta 1 blocker, right, that we use when we want to get people with hypertension but they have asthma kind of thing, or they've had a heart attack but they have asthma, so you don't want to aggravate the beta 2. So metoprolol is like our poster child there, and then you have esmolol and the atenolol and the betaxolol, and then there's this other one, acebutolol. So okay, a couple things we have to do with this. So while we have these beta blockers and they end in OLOL, if the rule was that they were supposed to be beta 1 blocking, there's a couple of these things that are breaking the rules a little bit, and they're not going to be just beta 1 blockers, or they're not going to be beta blockers at all. So there's two that are beta agonists, partial beta agonists. So one of them is featured right here, acebutolol, and you could think of it as being an ACE because it's not following the rules and it's actually stimulating partial agonist activity. And the other one is pindolol, which we'll talk about in a second. So they use PAPA, PAPA, partial agonist, is pindolol and acebutolol. And so we'll talk about how to remember pindolol, but acebutolol, it's the olol that's an ACE, and it's a partial agonist. Versus atenolol, which was also in that beta 1 category, but it's paying attention, right? It's paying attention, it's doing its job, it's a beta 1 selective blocker, it's atenolol. So if you remember atenolol there, acebutolol, metoprolol being the poster child, then you just have esmolol, which is short-acting, and that betaxolol being a beta 1 blocker. So that's there. So the hardest one's probably being esmolol and betaxolol to remember being beta 1 selected. but we'll, that you got to memorize some stuff. So then the non-selectives, right? There's propanolol. So now we're going to the next tier where all of these are admitting that they're breaking the rules. So there's propanolol, which is these non-selective beta blockers. Propanolol, panning, pan, everything. It's blocking everything. Propanolol. And then how I remember the pindolol is I think of it as an inferior, pin, P-I-N, pin, inferior. It's an inferior propanolol. Why is it inferior? Because it's not just blocking betas, it's also the other partial agonist. So pindolol, acebutolol, okay, so the propanolol, pindolol, and then there's timolol, and then the other one is nadolol. So the way I look at those is that timolol tried to be a non-selective blocker, but it failed, and nabetalol, there's no way. It's not a beta 1. Not a beta 1 blocker, it's a non-selective blocker. So timolol tried to be a beta 1 blocker, it failed, it's a non-selective. Nadolol tried to be a beta 1, but no, it didn't happen. So it's a non-selective. And then we just keep in mind that our agonists were pindolol and acebutolol, because one's an ACE and one's just an inferior propanolol, and it got bumped down. So if you remember also that there's one from each of those categories, a beta 1 blocker dominant that's an agonist, acebutolol, and a non-selective blocker that's a beta agonist, which is pindolol. And then you just have the non-selective beta blockers that are also alpha blockers. And so this would actually lead to vasodilation. And one that you probably heard a lot of on TV shows and stuff is carvedilol, right? Carvedilol. So how do I remember carvedilol is this non-selective plus the alpha? So to me, carvedilol, it's carving out the biggest piece that it can, right? And it's not quite, it's the one that's spelled differently, so it's the ILOL ending instead of OLOL. So carvedilol, it sounds like an olol, so something with beta blocking, but it's carving out a bigger piece, and so it's also an alpha blocker. And then labetalol is an ALOL ending. So again, tried to sound like an olol, tried to get by, but it was lying because it's labetalol. So it was lying, and it's also an alpha blocker. So, quick recap. If my general rule is OLOL should have been beta 1 blocking dominant, then we had acebutolol, which was the partial agonist because it's an ACE. And then there's that beam, and that's where the beam mnemonic probably helps for these ones that's in first aid. B, betaxolol, esmolol. Oh my God, nope, that's a mistake. I just made a mistake. Beam was the non-selectives. No, beam was the selectives. Metoprolol. Yeah, why did I think that? Metoprolol is a beta 1 selective. Metoprolol, betaxolol, esmolol, atenolol. It's paying attention. Pay attention. Atenolol, beta 1 blocking. Metoprolol, the classic poster drug, and then betaxolol and esmolol. Okay, and acebutolol. And then non-selective blockers are your propranolol, start there, propranolol, then it's got the inferior propranolol, pindolol, and then you've got the ones that tried to be beta 1s but failed. You got timolol and nadolol. And then you got your non-selectives with alpha blocking, carvedilol and labetalol, carving out a bigger piece, lying about it, carvedilol, labetalol. And then, again, just to recap, the PAPA there, the partial agonist is pindolol and acebutolol, because it's an ACE. So, that was a lot. But that was the sympathetic drugs, when you would use them, why you would use them, what they get you. And, one other thing we should talk about, as I realized I skipped over, was clonidine, when you would use that. So we said clonidine would drop blood pressure as a central effect, right? That's the one you think about. Methyl-dopa, good for pregnant women, that kind of thing. But why mention the kidney? So if we think about it, if that's acting centrally to sort of stop the signals from even going out to the kidney, then yes, the vessels by the kidney will dilate probably, but the kidney is capable of autoregulation. So even though it's facing that vasodilatory effect from clonidine, it can use its RAS system to stimulate the it can use the RAS system to stimulate that efferent arteriole and bring up its perfusion. Whereas if you use sort of a indiscriminatory blocker like phenytolamine, that has a peripheral effect, so that's going to be going up against the RAS system, whereas the central effect of clonidine allows the kidney to still work its magic out in the periphery by the receptors closest to it. So that's how I kind of think about that. Clonidine is a good way of bringing down pressure while protecting the kidney, and dopamine was a good way of raising pressure while protecting the kidney. And then we have all these other drugs that we talked about that you could just willy-nilly, if you need to, drop or raise accordingly. So that was a lot, and now we're going to talk about cholinergics in the next video.